Hello everyone, yes, so I'm Amanda Atkinson and I'm a senior researcher within the Public Health Institute at Liverpool John Moores University in the UK, and I was the lead researcher on the evaluation of the tools that we were testing in the DELTS project. So today I'll be presenting a few of the key findings. We've got a lot of data, but I'll be focused on some very important findings that I think are important in terms of the next steps and going forward. Just want to very quickly just acknowledge that this was very much a team effort. So I led the project, but partners from a range of countries had an active role in designing the project, collecting the data, and also analysing and interpreting. So just want to acknowledge the whole team there. I'm going to say a little bit of background, a little bit of contextual information to the project. I won't say too much, as I think we've had a nice introduction to the issue already today. I'll briefly mention the aims and objectives and the methodology that we employed, and, as I say, focus on a number of key findings, and hopefully we can move on to think about the next steps. And I know that's something that we will discuss in the panel discussion later on today as well. So we know increasingly that there's awareness that PIEDS are being used outside of professional sport and amongst the general population. There's also increasing evidence that people who are using these substances don't necessarily engage with healthcare services, and there's a number of barriers, and that includes fear of judgment and stigma, which is still quite prominent, and also the perception and, to some extent, the reality that healthcare providers don't always have the knowledge and the skills to be able to respond effectively, and that there is evidence to show that even specialist drug workers don't always have the knowledge to be able to respond to the needs of people who are using. We also know that generally the evidence base for the effectiveness of interventions is limited, and that applies to interventions that are targeted towards people who use, as well as healthcare professionals and the wider fitness industry. However, there's various e-learning tools that are available that are targeted at users as well as healthcare and fitness professionals, but these haven't been evaluated either. So to date, we're actually unaware as to whether these tools are being used in practice, whether they've been adopted, and if so, with what effect. So the rationale for this project then was to frame health services and fitness environments as spaces to intervene and provide support and information to reduce use and to reduce and prevent harm. And in order to do that, in order to make these environments health promoting, we need to make sure that the individuals working within them are accessible to people who are using a range of doping substances, and therefore we need to increase their awareness of the issue, their knowledge, and equip them to be able to identify identify use and harms. And I think really importantly, in a way that's culturally sensitive and a way that's non-judgmental, because we know that stigma is a big barrier to service engagement, and we need to make sure that we don't reproduce that stigma. So this project evaluated three tools. We aim to encourage people to increase their knowledge by engaging with the tools, and based on their experiences, we aim to gain insight into the acceptability of the tools, their usability, so how user-friendly they were, whether there was any barriers to use within their workplaces, their practical utility and perceived effectiveness. So I think it's important at this stage just to acknowledge that this wasn't an outcome evaluation. We weren't assessing the impact on knowledge and interaction and working practice, but it was almost the stage before an outcome evaluation. We need to look at the way in which these tools are implemented, interpreted and adopted within certain healthcare and fitness environments to be able to amend them, to then go forward and do a full implementation to measure their effectiveness. So the first tool was the Dopinglinkki learning modules. One was aimed at the healthcare service providers, such as doctors, nurses, and those working within drug services. And this, in its original form, was designed to target those studying medicine, so medical professionals and doctors. But we were interested to see whether it would be applicable to those working within the general field of healthcare, including drug service providers and nurses also. The second module from Dopinglinkki was aimed at the fitness industry, so coaches, personal fitness instructors and trainers, and this was a simplified version of the medical tool. And it provides a range of information from focusing on reasons for use, effects, how to identify information to try and overcome some of the myths surrounding doping drug use, and information on how to avoid stigma and interaction in practice. So it's an online self-directed learning tool, just a few screenshots here, a range of information including visuals as well as videos from experts across each country, and the provision of further reading. The second tool was the SafeU Fitness app, which is an online digital learning tool aimed at those working within the fitness industry. And again, it provides a range of information on levels of risk, for example, dosage and side effects. And again, just some screenshots. It's designed to be very user-friendly and something that people can dip in and out of in a practical way whilst they're on the go and within gym fitness environments. I know Vasilis will be saying a lot more about this later on this afternoon. So we had 3 tools that we were evaluating, and different countries participated in the various tools, but we all employed the same methodology, which was standardised across the countries. So first we recruited individuals working within the healthcare and fitness sector to pilot the tool. So some of these numbers might seem low, but this wasn't just an online survey or interviews. People had to sign up to take time out of the working day or time out of their, use their own time to set aside, up to a few hours to actually test the tool and then provide feedback through an online survey. We then took a subsample of individuals and conducted interviews to gain more information and a deeper insight into their experience, whether there was any barriers to implementation and what changes might be needed to take this tool forward and make it more widespread. So in terms of the sample, in terms of the healthcare professionals, it was predominantly doctors, nurses, medical students and those working in drug and alcohol services and needle exchanges. The fitness sample included coaches, personal trainers, instructors and also gym owners, and that applies to both the module and the fitness industry app. So I just want to touch on a few key findings. As I say, there's a report and there's lots and lots of information in there, but these are just some of the kind of key messages and considerations that we need to think about in terms of taking the project forward. So I just wanted to introduce some background information on the sample. So the aim was to encourage people who had previous little training to engage with the tool. And in terms of their previous contact and interactions with people who are using these substances, then most hadn't had interactions, but a significant proportion were suspecting that their clients and patients were using a range of substances. And this was particularly significant for those working in the fitness industry. They were less likely to have had previous interactions and they hadn't kind of brought up the issue and had dialogue around doping use. Yet they were suspected that their clients were using. A significant proportion, between 1/3 and 2/3, acknowledged that there were barriers in place in terms of engagement with health services, and that included stigma acting as the barrier, which I think is a really important consideration that we'll probably talk more about in the panel discussion later today, and also this idea of the perceived lack of knowledge amongst those working in healthcare professions. In terms of training needs, there was little previous training around PIEDS, but the majority felt that they did require additional information to be able to apply in their practice. And generally this meant that they did agree that there was currently a gap in knowledge, that the knowledge base wasn't great within their working environments, and that that the various tools provided a gap, that there was a lack of credible information currently, and the tools were filling the gap in terms of resource. In terms of usability, generally people felt that it was easy to use, the content was clear and easy to understand. However, I just want to highlight the statistics in grey there, which was the health service professional module. And as I said earlier, this was originally designed to target those studying medicine, and we tried to roll that out to different workplaces such as nurses, as well as drug and alcohol and needle exchanges. And generally there was the perception that it was a bit kind of unclear and overcomplicated for other health professionals, and I'll say a little bit more about that shortly. Generally, people felt that the information was credible and that it would help them identify myths, and it was providing a source of unbiased information. Now, in an ideal world, all these percentage statistics would be 100%. And I just want to again highlight the 75% there, the health fitness module. There was issues there that the unclarity for some individuals meant that they weren't able to assess whether the information was credible. It was also suggested that we need more referencing to support some of the claims and the information in there. Even though there's a reference list, people would have liked to have seen more references within the healthcare module. So in terms of practical utility and perceived effectiveness, again highlighting that this wasn't an evaluation of actual effects, so this is perceived effects, which I think is important to remember. But generally people felt that it helped increase their knowledge, therefore it allowed them to identify people who might be using within their services, and would allow them to apply the information that they'd learned to prevent harm. I think really importantly, it was also acknowledged that the information had made them more confident that they had the knowledge, and therefore would be more likely to approach and bring up the issue with their clients and patients, but in a way that was non-judgmental, in a way that was discreet, and a way that was non-moralising. And I think this is really important going forward. The majority of people, particularly which might be expected, those working within the healthcare environments, talked about how the information would allow them to treat and respond to harms. But this also applied to those working within the fitness industry. There was very much a focus on treatment and responding to harms within their kind of professional roles. When it comes to the idea of prevention, there was a bit more uncertainty around the use of the tools for prevention and reducing use. So some people had maybe a more simplistic view of behaviour change and prevention, in that they felt that if they pass on the information and the factual information to clients and patients, and they would act and make a rational decision, therefore not to use these substances. However, we know behaviour change is much more complex than that. Information provision isn't always effective on its own, and people don't always make rational decisions based on cost-benefit analysis. And some participants did acknowledge that and were a bit sceptical as to whether they had a role to play in prevention, and whether it was their role to do so, whether it was more harm reduction and treatment. Practical utility, the majority of people would recommend the tools to a friend, and they were willing to spend time using the tools in the future. However, there was a number of barriers that were discussed, and a number of barriers that I think we need to respond to going forward with the project. The first being the idea that generally people felt that within healthcare services and within the fitness industry, a lot of people just don't see this as their role. They don't have the knowledge, and they don't see it as being within their role to actually respond and intervene. And generally we need to raise awareness of PEDS use as a public health issue, and increase people's willingness to enhance their knowledge. Stigma is something that I've mentioned a few times, and I think it's a really important consideration. It was acknowledged that stigma does still act as a barrier, and some individuals, although they discussed how the tool might have give them information to act in a less of a non-moralising way, some individuals, particularly from a harm reduction perspective, felt that the language within the tool itself might reproduce that stigma, and we've got to be careful that we aren't passing on information to healthcare providers and fitness industry professionals that will reproduce stigma as a barrier. And I've just highlighted this quote here from a policymaker in the UK, who suggested that a way of kind of overcoming the negative impact potentially of stigmatising language is to consult with the community, to consult with people who are using, and get their insights on the language that's used, to make sure that we can prevent that kind of language and discourse being reproduced. Missing content, so very much a tool that focuses predominantly on anabolic steroids, and people suggested there was a whole range of additional information that they'd like to see. I'd just like to quickly pull out this kind of idea that tools like this need to be constantly updated and reviewed. So the evidence base is constantly changing. We're doing more and more research, and we need to make sure that tools reflect the updated and the changing evidence base. From a harm reduction perspective, those working within health services and drug treatment and drug services more generally felt that we need more harm reduction. And maybe someone can, as my time's up, maybe you can ask me a bit more about the barriers as questions, and I can draw on some of the barriers, unless I can have a few more moments. Or... Yes, thank you very much. So as I said earlier, the healthcare module was regarded as a bit unclear for some participants. So generally it was felt that it was quite text heavy and it lacked interactivity. People acknowledged that various people learn in different ways, but generally people wanted more interaction and more visual content, and they felt that that would help simplify the module and potentially provide a resource that they could consult whilst interacting with a client and patient, or something they could dip in and out of within a consultation. It was felt to be too scientific for those who weren't studying medicine, and therefore a bit inaccessible and too academic, which meant that it was frustrating for some, and it was just more of a time burden as people were having to look up terminology, and therefore they weren't retaining the information due to the complex nature of some of the content. And this issue of time generally didn't just apply to the healthcare module. Generally, healthcare providers and fitness industry professionals have very limited time, and they also felt that within the limits of their time, that responding to PEDS use wasn't necessarily a priority. And if they were having to apply the knowledge that they'd learnt and pass that on to clients and patients, and aid interaction based on their knowledge, that they'd need more time generally to do so. And most had actually completed the tool in their spare time. It was generally felt that organisational support and employer support for the tool was needed if it was going to be rolled out and to become routine practice in the future. However, in reality, people were unsure as to whether senior management would endorse the tools, particularly because of this issue of priority, professional roles, whether organisations saw it as their role to prevent and reduce harm and respond to the issue. It was suggested that accreditation, which is a long-term aim of the project, would help boost organisational support, and making the module compulsory in the long term was probably the best way forward. So to very, very quickly summarise, I think the results are very promising. So generally people recognised the need for the tools. They were willing to engage and felt that it did begin to fill a gap in that there was a lack of credible information and resources information, both nationally and internationally. However, in the current form, the fitness module and the SafeU app were accepted to a greater extent than the healthcare module, which needs more adaptation, and it needs to be simplified to make it more accessible. A number of barriers I've highlighted, and I think it's really important that we consider these moving forward. And we, as a researcher, we always say this, but we need more research. We need to adapt the tools, change the tool in terms of some of their content. We need to address this issue of professional roles. So we need to not only market the tools, but that needs to be part of a wider package where we try to promote healthcare services and fitness industries as environments that can promote health in relation to PEDS use. So in the green, we're up to the stage now where we're adapting the tools, and the next stage is to gain funding and to fully implement the tools within specific organisations. So the current research included individuals working across a range of different organisations, but what we need to do is have agreement from a number of organisations so they can implement the tool across their workplace, and then we can measure the actual effects on knowledge and interactions, and hopefully in the long term the experiences of people who are using. So that's all from me. Obviously time for questions, I think, but I'd like to open up the questions as well to the whole DELTS team, in that it wasn't just myself as the researcher. There was a number of people that had an active role, and they might be able to answer some of the questions specific to their cultural context. Thank you.
Thank you, Amanda.